All right, welcome to the scan along video for the knee region. So in the knee region, we're going to break this up anterior, medial, lateral, and posterior. We're going to start anterior and looking at the common extensor mechanism. When you look at the knee, always make sure you have a little bit of a bend in the knee, about 20 to 30 degrees. We're using just like a bolster here, just to put the knee in and rest it comfortably in that position, and that's going to put the extensor mechanism a little more taut. Otherwise, it's going to be pretty tough to image that structure. So once you have the patient set up, you're going to take your probe and put it just at the apex of the patella, and this is we're going to see the quadriceps tendon. So it's going to come down and attach to, distal or proximal. Is to the left of the screen, and distal is to the right, and so this is the patella here, this bony acoustic landmark. We want to identify that right here so we can start to look at the quadriceps tendon. Here, once we're looking at the quadriceps tendon, before I even really look a lot at the tendon, I'm going to look for joint effusions, and the reason is because that could be involved in a lot of different pathologies at the knee. So where effusions occur is between the prefemoral fat and the suprapatellar fat. So to locate the prefemoral fat, we need to first locate the femur, which is going to be this kind of acoustic landmark deep here. And this is the prefemoral fat right above. Here's the patella, and here's the prefemoral fat. And so most people, if you move a little bit medially, you might be able to identify a little bit of physiologic fluid in here, but we're looking for, and you can see almost this is physiologic fluid. You can almost compress it a little bit in here, but there's really no fluid there, any pathologic fluid. But that's where you're looking for fluid here, and where it's going to go is it's probably going to move all the way up the thigh a little bit, or it might be inside in the medial portion of the knee is where we're usually checking for knee effusions as well. So once we look for a knee effusion, and we're looking at we're going to come back and look at the quadriceps tendon in a little bit more detail. As here, I like to slide the probe both medial and lateral to look at the entire quadriceps tendon. As you come medial, you'll run into the vastus medialis, and you'll have to turn your probe a little bit to locate how that muscle attaches all the way down. You can see here it's common kind of attachment part here onto the common quadriceps, and then some of the aponeurosis and retinaculum as well. And so you can see where my probe angle and position is. It's all the way down there. That's how far down the VMO goes, and you don't have to turn your probe. So you align the probe with the connective tissue of the vastus medialis, and then bring your probe, and you can do the same thing lateral. As you come lateral and go to the lateralis as well, and you'll do the same thing here, where you'll need to change the probe positioning up a little bit to make sure you see how that attaches too. Then once you've done that in long axis, you take your probe and put it into short axis, and here you can look at here's the common tendon right here, quadriceps tendon here. This is the vastus medialis. If we move laterally, you can see the lateralis coming off here, and if we continue to slide up, we're going to see the rectus femoris come off right around here. You can see how far up I am on the thigh. It doesn't turn into muscle till pretty far up in the thigh region. And then here we have, all four quadriceps muscles here, where we have the rectus femoris, medialis. Deep here is the intermedius. Here's the femur underneath, and then here is the lateralis too. So we'll make sure we take a good look at all those structures, make sure they're intact, and they're where they should be. After you've looked at the quadriceps tendon, I like to continue down off the patella and look at the patellar tendon as it comes off the distal part of the patella here, and I'm in short axis. It's this structure right here. You want to make sure you look at that all the way down to the tibial tuberosity in both short axis, and then here's in long axis here, going all the way from tibial tuberosity distal all the way up to the patella. And so make sure you're imaging this structure all the way up and down. Here's where you can start to identify any focal enlargement here, but definitely in short axis, where we should see it looks very hyperechoic and different from the connective tissue and fat pad underneath. We're looking for any kind of focal enlargement, or if it look hypoechoic, anything like that. While you're here, you can also look at the medial retinaculum. I like to look at that more anteriorly than when we start doing medially. But if you come off the patella and just drop medially, you'll be able to identify it here coming off the patella to the femur, right here. And why I like to look at this, you can have them lay their knee out, but here you can just take your finger and just stress the patella laterally, and you can watch the problem is if you keep the probe on the patella, it's going to look like the femur's moving away. So if you keep so there you can kind of see it looks like to the left of the screen the femur's moving, but really it's just because my probe hasn't moved off the femur. So you can just use the femur as a stationary, and when you move on the patella, the problem is that you kind of lose contact often with the patella. So if you're trying to stress that structure, the retinaculum and the medial patellofemoral ligament here. Okay, so after you've looked at the anterior structures, when we look at medial, make sure you have them take their leg, and if they can externally rotate their hip, so you can kind of have good access to the medial portion of the knee. And here we're going to look at the MCL and the pes anserine and the medial joint line. So first thing I like to find is the tibiofemoral joint. And so I take my probe, and if you're up here, where I put mine is at the VMO, obviously this is femur, and so we know we need to come distal until we run into the tibia, and then here's the meniscus. And so you can move the probe posteriorly to identify more of the meniscus there. Now keep in mind the ultrasound is very limited in its diagnostic value for meniscal tears. If you see a parameniscal cyst or a tear, it's probably more specific than it is sensitive, but I use other imaging modalities to rule out a meniscal tear. But right when you find the meniscus and you find this joint line, we're going to come right above here, and we're going to start looking for the MCL, which is going to be this connective tissue right here, right above the medial meniscus. So here's its proximal part here, and if we move down, here it is right over to the joint. Here's the meniscus, and I think the thing that throws people off about the MCL is it goes down quite far on the tibia, and so here it keeps going. Here as it moves and attaches real far, and it keeps going down all the way down the tibia. So it can go down quite far on the tibia. The pes anserine is overlapping with this, so it can kind of make it difficult to distinguish the MCL and the pes anserine. But right around here is you're looking for any kind of focal bursa, swelling of any kind. And then if you move your probe maybe a little bit posterior and angle it a little off, you should start to find the pes anserine here. It's going to look almost a little thicker, and you should also be able to, you can trace it to some of the structures behind the knee. If you have a hard time and you're kind of getting like lost and I can't distinguish between them, take your probe, put it in short axis until you find one of the, and you kind of just move it right to medial, almost medial posterior. And then we're right here We're at one of the structures that attaches to the pes, and from here we can follow this structure all the way here on the tibia where the pes attaches. It's a little thicker here. Again, I'll do that again. So, if we are medial knee, and we'll do this again when we do the posterior knee, we'll do this a little bit more. So you'll have another opportunity to find these structures here. And you can take your probe into long axis and follow these structures here as they go over top of the knee, and kind of attach down onto the tibia here at the pes. And there's three of them obviously attached to that structure as well. Okay. So then we're gonna transition now to the lateral knee, and here you can take away the bolster and just have them kind of lay down there, or you could even just have them relax on the bolster, kind of in the lateral knee, just so they're comfortable, but make sure they're here. And I have a slight bend in the knee, and so that should help us. Here we're going to look at the lateral collateral ligament and the biceps femoris, as well as the common fibular nerve. The LCL, hopefully you can kind of just palpate that structure, but there's a couple ways we identify that. First thing we're going to look at is just like the medial, we'll look at the lateral joint line and the meniscus here, just like we did on the medial side, and we can follow that both anteriorly and posteriorly here. And so here we're imaging it right here. The LCL, we're going to first find this groove right here in the lateral distal femoral condyle, and this groove is where the popliteus tendon attaches. And so it's fairly distinguishable right here, the popliteus, and we're looking for right here, right above that is going to be the LCL attaching here to the distal femur, and we're going to follow this structure all the way down till it attaches down here to the fibula. Now, if you're having a hard time kind of distinguishing these structures and seeing them come down, it's okay. A lot of times it blends right next to the fibularis. I'm sorry, not the fibularis, the biceps femoris tendon. And so we're seeing it here. And then if we want to see where it attaches, we can actually go into short axis here. And we can do a couple different things. We can look for first the first kind of muscular structure as soon as you come off. This is the fibular head here. As soon as you come off it and move proximal, you're going to see this, should see this nice connective tissue, and it should turn into kind of this big muscle here. And that's how you know that's the biceps femoris, as it comes and attaches down here onto the, right here onto the fibular head. And if you came, so right here is the attachment of the fibular head, and then here we can probably follow this other structure coming off the fibular head, and that should be our LCL here. Nope, I'm sorry, that's still the fibular head. Right here. And so this is the LCL. You can see a little tougher to distinguish here. And it's going to attach right next to where the fibular biceps femoris attaches to. So that can make it a little bit tricky. But you can look at them in long and short axis, and I encourage you to do that to make sure you kind of identify and distinguish them. The last structure distally we're going to look for is the common fibular nerve, which can be tough, but You're going to see with nerves, if you move a little faster, it might be a little easier to find. And so we're going to come right where we were, right over top of this fibular head. And to the left of the screen here is posterior. And to the right is, to the right of the screen is anterior. And we're looking for a structure that's going to move from over here, posteriorly, wrap around the fibula, and dive anterior and deep. And so here we're off the fibular head. There's the I'm proximal, come right onto the fibular head, and we're looking for something that's posterior, which is actually right here. Move as I slide down. It's going to move here, over top, and dive deep. Again, so we're posterior, fibular head, right as it appears, and it dives deep. And so you start moving the probe faster and faster. You might see that I'm seeing something move from the left to the right, and that's the common fibular nerve. Here it looks pretty, like a typical nerve, maybe that honeycomb appearance. We can see different fascicles of the nerve. And then as it moves and translates anterior, you can see it almost looks really elongated, but that's just because the angle of the nerve has changed. And so you're almost looking at it in like an oblique view of that nerve. So you can move the probe to distinguish a little bit better. But that's an easy way to look at and make sure you find the common fibular nerve, because it can be tricky, and we're looking for any kind of focal enlargements of that nerve or swelling of that nerve, anything or fluid around it, anything like that. Okay, the last view we're going to look at is posterior. And the posterior knee, there's a lot of things back here, but if you can kind of think of your anatomy, try to keep it simple in your head, you can distinguish things. So we're going to start medial posterior. And we're going to take our probe, kind of, if you look at the knee pit, we're going to come right, I like to come right above it, and right above it and medially. And then I like to slide, and so just to orientate to the left of the screen is midline or medial, and to the right is lateral. Okay, so I'm moving medial to the left, lateral to the right, and this is going to be tough. So if you look, as soon as you look midline and you're on proximal, you might be able to notice the neurovascular structures. But medial, we're going to look for, there's a couple of different things we can look for. The first thing we're going to look for as we slide down is this structure right here, is the medial distal femoral condyle. Once you find this bony acoustic landmark, then you can really start to move off and identify the other structures. From here, again, if we come more medial, right here, this is the sartorius muscle, right here. If we move up a little bit, we can actually see that this right here is the gracilis, and we can follow it up and see it turn into muscle here. And so we have sartorius here, gracilis here, and then this big one is the semimembranosus. And this little guy on top is the semitendinosus. Semitendinosus is tendon distal and more muscle proximal, and membranosus is the opposite. It's more muscle distal and more tendon proximal. But we could slide up and watch the kind of the tendinosus become muscle too. But it's important to know at least tendinosus and membranosus. So we come back again to this medial femoral condyle. Then we can start looking for a few other things. So here is again, the semimembranosus just coming just proximal. And then if we come medial, or I'm sorry, not medial, lateral, here we see the medial gastroc. And we can move down into the calf more to make sure that is the medial gastroc. But this is the medial gastroc. And here's where we're looking for any kind of like Baker cyst will always occur between these two muscles, the semimembranosus and the medial head of the gastroc. And so we're looking for any kind of fluid-filled structure there. We'll also look at it in long axis. And so from here you can see semimembranosus here and medial gastroc here. And so we're looking for, is there any kind of fluid occurring between these two right here? And so here we actually do see a little tiny anechoic pocket of fluid. We want to make sure that's not a vessel. And you make sure it's a vessel by, is it continuous? Does it end? And so here you can see it kind of ends. If we move distal, it kind of ends as well. Vessels will continue to be vessels. And so actually there's a tiny, tiny Baker cyst right between here and this one right here. That's a pretty small one. Generally they're not compressible either when you press on them. So that's between your, again, because M&M is a good acronym to think of. So semimembranosus and medial head of the gastroc. All right, now we're going to turn back into short axis. And so here's the medial femoral condyle here. As we move midline, here's the medial gastroc and the neurovascular bundle here. And as we become lateral, here we have the lateral head of the gastroc. And we actually can see there in a little bit of the, should be plantaris. And then here as we come up proximal, here's where we can actually see the biceps femoris muscle here, and the two parts of the biceps femoris here and here. And so you can, again, you could do the same thing we did laterally where we follow the biceps femoris here all the way as it turns into tendon, and we can follow that all the way where it attaches to the bone. Okay, all right, this completes the scan along for the knee region.